We thought we would start some of these monthly little seminars, and they're not, super complex, but you're going to hear things you've never heard before, I can guarantee you, about Parkinson's. This is all about neurochemistry that nobody really knows. Neurologists don't know this stuff. And we're going to talk about that a little bit. My name is Clarke. I'm a rehab doctor, and the therapist will say, really, he's a rehab doctor? I didn't know that. So we're going to talk about some of the neurochemistry of Parkinson's. And we thought, the community really doesn't know what we do here at PAM. And doctors would be welcome to come because there's a lot they can learn about the neuroscience of Parkinson's that, they get in a mode, and they're great at what they do. They're great with the medications, and they're good. But, you step back into the science part of this, and it gets even more fascinating. And there's so much more we can do. So we're going to give these seminars maybe once a month, different aspects. And if you have things you want to hear about, let me know. And we'll throw together a thing, and we'll do that month. All right, so we're going to talk about Parkinson's. And those people who are out here, does anybody have Parkinson's family? Or does anybody here have Parkinson's? Okay, there you go. The therapist can also tell me, oh, there's therapists here. They can also tell me what the symptoms of Parkinson's are. Give me some.
Steady gait. Started with the tremors.
Steady gait, tremors, good.
Altered mental things.
Perfect, altered mental status.
After a while, not right at the
Yeah, exactly, it's later in the game, right? All right, so yes, you get mental status changes late in the game. And you've listed a lot of them here. You listed the resting tremor, which is really one of the first signs. And the other thing that the therapists are dealing with all the time is the rigidity, the stiffness that you can't seem to overcome. And of course, the big sign that the therapists watch are the gait, shuffle gait, right? And you mentioned the confusion and dementia. About a third of them will get that later in the game. A lot of people skate by without it. The speech therapist, they'll see dysphagia where they have trouble swallowing. So all of those symptoms are part of the whole complex of Parkinson's. So what is the problem with Parkinson's? Who knows the answer to that? What's the neurochemical that's missing?
I know what it causes it.
Dopamine. Yes.
Dopamine.
Christy, 2 points. All right, so yes, it is dopamine. And we have a drug that boosts that dopamine. It's not dopamine, L-Dopa. It's actually a precursor to it. It's from phenylalanine, and then the body uses it to stimulate the dopamine receptor. So we use L-Dopa, and it works. That will address most of the stiffness, the tremors.
I didn't know loss of
Smooth
smell.
out the gate. What?
I didn't know loss of smell.
Loss of smell, yeah.
Yeah, that's a thing.
Yeah.
I didn't think that.
Of course, COVID does that. Yeah. Did anybody have COVID, they lost their smell? Yeah. Yeah. Taste and smell, yeah. Everything tasted like peanut butter and smelled like peanut butter to me for a year.
It's still not
Exactly, yeah. All right, so you have these dopamine pathways, and this is, you guys that have seen MRI, you'll see these things on the MRI reports. And if you'll recognize some of these things like the cortex, right? And the pituitary gland down here at the bottom of the brain. And this is the main dopamine area. And the other one is a substantia nigra, which is right here. And it goes up, and you'll see this other little blue line here, or the other little red line, actually. So the ventral tegmental dopamine pathway goes up, and the dopamine synapses on areas in the cortex. And that part of the area is really, or that part of the dopamine pathway addresses a lot of the motor functions, but also the pleasure centers. And that plays a role in addiction. And I know that when we were in college, we all had overdeveloped ventral tegmental pathways because we were all about being college students and, oops, sorry about that. And so the pleasure center was hypertrophic, and I could probably name names in the room and say, yeah, you have a problem there too. So, so that's the ventral tegmental pathway. That's the substantia nigra pathway is the other big dopamine area, and it goes to the caudate nucleus, the basal ganglia. You've seen those on MRI reports. And that governs the movements, the tremors, and the stiffness. So both of them have to work. But the problem with Parkinson's is that you lose dopamine. What happens, and we don't know why, but the dopamine neurons die off. And not only do they die off, but the receptors that they go to, like up here in the cortex, so the fibers are running up here, and they synapse on new cells up here that are going to do the jobs. Well, the receptors in these neurons up here or in here, they don't have the fibers active anymore, so they die off. So you lose dopamine and you lose the receptors and nothing works. The L-DOPA works for a while. The problem is that it doesn't stop the disease. You still are going to lose the neurons. And we're going to talk about how can we fix that. And this is where the neurologist could really benefit. So the dopamine, the L-DOPA, will eventually lose its efficacy after 4 or 5 years, but you bought 4 or 5 really good years where you're moving and you're walking and you're talking. But after that, then you've still lost all these neurons and they're not coming back. And then the dopamine has the opposite effect. It starts making, the L-DOPA, it starts making these strange movements, and you see it's called like athetoid movements, what we call it. It's called extrapyramidal symptoms. So that's what develops later in the game when the L-DOPA doesn't work anymore. So you want to get the dopamine cells to live, and you want more dopamine out of those cells as long as you possibly can. So how do we do that? I had a professor that was on my dissertation committee when I was doing my PhD work, and he is a neurochemist, and my PhD was in neurochemistry. And he said, you know, the neurologists have it all wrong. All they do is focus on this L-DOPA. And there's more to it than dopamine. There are other neurotransmitters. You have 3 more neurotransmitters that goose the dopamine cells and crank dopamine out. So you have acetylcholine of the nicotinic type. You have glutamate, which is an excitatory neurotransmitter also, and you have GABA. Now, each of these will stimulate more dopamine coming out of these cells. The GABA is inhibitory, but I'll show you how it changes to excitatory, so even that stimulates these dopamine neurons to start cranking out more dopamine. So nicotinic acetylcholine is the one I want to talk about, because nicotine will preserve the neurons and keep them from dying off, so it prevents the death of these neurons, which is what we're after, and it will also make the dopamine neurons that are there squirt out more. I got a lot of pushback on nicotine, and I still do. People don't really, they've been convinced that nicotine is an addictive drug, it's going to kill you for sure. And when the lawyers were suing the tobacco companies, they put out all the press that nicotine was more addictive than heroin, but it's really not true. Nicotine works a lot like Adderall. It will increase the output of dopamine. It makes you more alert, but it's also a calmer. I use it in several of the other PAM hospitals on traumatic brain injuries where the patient comes in and they're agitated and they're thrashing, and we stick a nicotine patch on them and they calm down. You don't have to use all the psychotropic drugs to calm them down and put them to sleep, and we'll talk about that in a second too. So nicotine does all of that, and it can preserve those neurons. So here are the benefits of nicotine. Nicotine will increase the dopamine output and preserve the neurons, and it will also slow the Parkinson's progression, especially in the caudate nucleus where the motor symptoms are. And we know that because those studies actually have been done. Smokers have a decreased risk of Parkinson's, and it's because of that, because the nicotine will preserve the neurons, so they don't even have the disease process. So I'm recommending everybody go to the store and buy a stogie and just fire it up, get a glass of wine, sit there in the patio. All right, so it does all of that. And in addition to that, this is kind of the cool part, we're trying to make new neurons. And when we found out we have stem cells in the brain, my big thing was to try to get those stem cells to convert to neurons. Nicotine will also help do that. It will change the GABA, which we talked about a second ago, where we talked about the GABA turning into excitatory neurotransmitter and start making dopamine. So nicotine will do that as well. So I use a nicotine patch. 7 milligrams, you can buy them over the counter, and they come in 21, 14, and 7 milligrams. Cheap, well, fairly cheap. And you just stick it on your tummy. I'll show you how I do that, because you don't want it all the time there, but you can kind of pulse it, and it works better. That's an easy way to do it. But you also have a chemical in your bodies that converts fat to energy. It's called acetyl L-carnitine. And we have a vitamin supplement that we use in the PAM hospitals around the country, and we use it here too. And it will make more nicotinic acetylcholine. The vitamin complex is called Nupinex, and we use it here in lots of different neurologic diseases because we really need to promote those neurons to everywhere, whether it's a stroke or whether it's dementia, and we use it all the time on different neurologic things because it works. But the other thing we can use to make more nicotine is we can use pregnenolone and DHEA. Those are hormones. Those are hormones that come out of your pituitary that's made from cholesterol. I'll show you that in a second. They stimulate a receptor called a sigma-1 receptor, and that drives more nicotine acetylcholine, which then does all of that stuff we just talked about. It makes new stem cells, it makes more glutamate, it preserves the neurons, all the things we just talked about. So if we replace two hormones, we can actually get even more bang for our buck. So we've got this new block of neurosteroids that drive not only more glutamate, which is going to make more dopamine, but also more nicotinic acetylcholine, which makes more dopamine, and it turns GABA from an inhibitory neurotransmitter, which is stopping dopamine production, into an excitatory. Now you got three big influences on those dopamine neurons that are squeezing out more dopamine from all of those dopamine neurons. And you get that other advantage of the nicotinic acetylcholine preserving them so they don't just continue to die off in the natural progression of Parkinson's. Neurologists don't know all of this, so that's kind of why you've got to think outside the box. You just can't give everybody L-DOPA and think you've done the job, because you haven't done the full job. You can actually prevent the progression, and we know that we can do that because there's studies on that. So now you have this new block. So if we go back up a step, now you have neurosteroids, sigma-1, and the nicotine increasing dopamine, the GABA making more dopamine, and the glutamate making more dopamine. So you got that. If you go back up a step, you go, well, how do you get more pregnenolone and DHEA? Well, you get it from cholesterol. So cholesterol is the mother of everything. It repairs every cell membrane. Everything you have comes from cholesterol, every cell membrane. And all of these hormones that you make, whether it's progesterone, estrogen, testosterone, they all come from cholesterol. So you don't want to really inhibit your ability to make cholesterol, and that's become the byword of every aspect of medicine. Everybody is on a statin drug. That's probably not the best thing for neurologic injuries or neurologic diseases. So you can see where all of these neurosteroids, estrogen, progesterone, testosterone, and DHEA. And not only does pregnenolone and DHEA preserve those neurons, but testosterone does. It protects the dopamine neurons. It protects all of the neurons in your head, but we're focused right now on these dopamine neurons for Parkinson's. Estrogen and progesterone, there are lots of studies that show that these hormones preserve these neurons and make more dopamine. So when I first started patients on hormone replacement back in the early 2000s, oh boy, did I get a lot of pushback, because the Women's Health Initiative have just come out. Everybody was, oh my God, I'm going to get breast cancer. I'm not taking those hormones. The doctors thought I was nuts. So finally, in the past 20 years, they finally come around and they understand that these hormones are good for the brain. And I think the new thing that you'll see more and more is that cholesterol is something you don't want to limit. It's something that you desperately need to fix things. If you think I got a lot of pushback from hormone replacement in 2002, you can imagine what I'm getting from nicotine. So again, it's every day. It's, come on, guys, catch up on this science. This is what really happens. So the patient comes into the hospital, and we've got patients in the hospital right now, and they have these they look like Parkinson's patients. And we see kind of this blank face, and their movements are real slow and deliberate. I mean, just all of those symptoms we just talked about. They're also agitated, so they put them on antidepressants. So one of the ones we always have used in the past for brain injury, because they're agitated and flailing around, is this quetiapine. Quetiapine, it blocks your dopamine. That's exactly what it does. Well, that's what I need. So I've got to stop quetiapine, Seroquel. All of the antidepressants that are listed here, Risperdal, Desrel, Wellbutrin, Vibrid, Geodon, Abilify, Zyprexa, they all block dopamine. They address depression, but it sabotages everything we're after. I want more movement. These patients are stiff as a board. They're blank stares. They're not thinking. Their brain's not clear. So I want to clear all of that off. In the old days, when I was working at Bentov ER in the psych ward, it's a lockup ward, and that's a stressful day if ever there was one. It's actually, you're there for 48 hours and you don't sleep. So we used to load these patients down with Haldol, and it was great. They kind of came around, but mostly they slept, which is exactly what we wanted, so I could go to sleep. And all of the over-the-counter sleeping medicines, just look at the list of things on the back of the box, and they all block dopamine and acetylcholine, nicotinic acetylcholine. They're anticholinergics. So all of those are really sabotaging what we're desperately after. We desperately want these neurotransmitters, and we're just eliminating them for convenience. And yeah, the patients are less depressed on these medicines. They do better kind of functional with the family, but you're really destroying dopamine. So what do I use instead? Well, I use this nicotine patch, 7 milligrams. I put it on every Monday. I take it off on Tuesday. Put it on Thursday, take it off on Friday. The reason you give them a holiday in between is that the receptors get saturated with nicotine. And the receptors go, well, I don't need any more, I'm fine. And they quit sending messages. They quit doing the job we want them to do. So it was called habituation. So if we take the nicotine away and we put it back on board 48 hours later, the receptors go, hey, I hadn't seen you in a couple of days. And so they start working again. So you mentioned Simitrel, and yes, Simitrel, this amantadine, that works. That was one of the original anti-Parkinson's meds, and it works by increasing the nicotine acetylcholine in your brain. It also bumps up the dopamine. So that's why I don't think they knew all of the details about Simitrel when they came up with this. It's an old drug, but it works. So that's a good one to try. I don't usually use it because I can go straight to the nicotine patch. The mirtazapine is called Remeron, and it has lots of neat benefits. It kind of increases appetite. It's a great antidepressant. It increases your dopamine. So that's my go-to for antidepressants in Parkinson's patients and in anybody that has these movement disorders. I want dopamine, I want norepinephrine, I want all of those things, and I don't want to inhibit them with these antidepressants. Sertraline is Zoloft, and it's a great antidepressant. It doesn't interfere with dopamine, so it's usable. If all you want to do is decrease depression, that's great. But if you also want to make new brain cells, more dopamine cells, but everywhere, whether it's a stroke or whether it's dementia, you don't really want to use that. I would go with something else, because you want these stem cells to be stimulated to morph into new neurons. So Zoloft doesn't do that. And I'll see a lot of patients come in and the doctor will start them on Zoloft because they don't know that part about Zoloft. And it's a great antidepressant, but I don't use it. Melatonin, that's another point about what causes the problem to begin with. Why do these cells die off? We think it's probably genetic. It may be autoimmune. It also could just be a destructive sequence of events where you have increased oxidation, free radicals. Melatonin fixes that. It may also be neuroinflammation. Melatonin suppresses those inflammatory cytokines that we learned about during the pandemic, the cytokine storms. It also neutralizes a lot of the excitotoxic neurotransmitters, excessive things from the brain damage itself. So I use melatonin all the time in all of my neuro patients. And it's more than just a sleep medicine. If you take nothing away from this, remember that melatonin is a brain protector. And we talked about DHEA and pregnenolone. So here at PAM, I give all of this neurochemistry in there, but that's not enough. You have to have chemistry plus practice, just like playing the piano. Just because you put the chemistry in doesn't mean the patient's going to walk great and talk and have interaction and be able to brush their teeth. You still need to practice, and that's what the therapy does. So you combine the two, you've set the stage, you've laid the groundwork for making new brain, and everybody's happy upstairs in the noggin, but you still have to make those synapses, and that's what happens when you practice the piano. At first, you're really clumsy and you don't know what you're doing. After you've done it for a couple of weeks, you played that song, it's stuck in your head and you'll never forget it. So that's what we do with our therapies here. So we combine that in a rehab program with the chemistry, and you can actually heal the brain. And here's what I can show you about that. We're doing these studies with University of Houston, Clear Lake, and these friends of mine in Boulder, Colorado came up with this WAVI machine, which I use to evaluate. We can show with this EEG coherence that we're making new connections. This is the coherence graph. Each of these little dots are the electrode in the helmet. So it's a little helmet, it's hooked up to an EEG machine, and these are the different wavelengths of an EEG, and that's not important now. But what the computer does is it figures out what is most likely connected to what. So this is the front of the brain, this is the back of the brain, this is the right and left sides. So you can see these electrodes in this helmet really are recording electrical activity on all the different hemispheres and parts of the brain. And they're figuring out what's connected to what. After 30 days on the chemistry that we're doing, is every red line means that you made a new connection. So the computer's figuring out, oh wow, that's a brand new one. So it changes the color to red, but there's a mathematical significance to it. But so we know after 30 days, look at the new red lines we made in every frequency. And in this guy, you can see that, almost see where most of the repair work was done. So we know we made new brain, we know we made new connections, and we can prove it. No one has ever been able to do that before. So that's really exciting. That's why we've got the research project going. And after 30 more days, you see more red lines in different spots. And finally, after the fourth one, you're still seeing more. Some of the lines have turned blue. Well, that means they're working again. They're just working normal. They're not brand new. They're now 90 days old or 60 days old. So they turn back blue again. But the red lines mean we made new connections. So this guy was progressive Parkinson's. He was 87 years old. He had the cognitive decline. He had the fatigue. He had all the motor symptoms. And he had the tremors and the memory loss. After we did all of this, a lot of that resolved. Certainly the motor part resolved. The tremors definitely got better. This next patient is another example of that. This is a woman. She is what, 68. So she was diagnosed with Parkinson's. She had a lot of the emotional part of this too. She had the depression, the anxiety. So we started her on this program. And you can see that in her first baseline, you see everything's blue and green. After 30 days, you see all these red lines coming in. And in her, look, she's got the red lines coming in mostly on the right side and in the back of the brain. So you can almost tell where the body says, I need new synapses. So it begins to generate these new connections down those fiber pathways I showed you on the illustration of the brain. So that's pretty exciting to be able to show the patient, hey, we're making new brain here, so don't give up. And then I turn them over to the therapist, and the therapists are walking around and they're practicing these motor movements. They are also going to try to get the thought process and the cognitive side of it going. And all of that involves getting the new synapses and the new neurons. So that's pretty much a synopsis of dopamine, neurotransmitters, and that's the current state of the art. And we're way ahead right now. I'm working with these guys in Boulder and also with the guys at University of Houston, Clear Lake. And we now can show that things that nobody else has ever been able to show. And it's really exciting. So it's all about chemistry and therapies. That's what we do at PAM.